on at preterm gestations, epidemiology and the biological basis for outcomes. A very, very interesting topic for all of us to look into today, First, let me introduce our moderator, Dr. Rohit Kumar Vasa. Dr. Rohit Kumar Vasa is the attending neonatologist at Anne and Robert H. Lurie Children's Hospital, Chicago, and chair of pediatrics and neonatology, site leader at Mercy Hospital and Medical Center, Chicago. Thank you, Dr. Vasa, for joining us today. So he will be coordinating and he will be moderating the 15-minute question and answer session after the presentation of about 45 minutes. And it's my pleasure and privilege to introduce our distinguished speaker of today, Dr. Tonsei Raju. He's a board-certified pediatrician and neonatologist who had a long tenure as professor of pediatrics at the University of Illinois in Chicago. In 2002, he moved to the Washington, D.C. area and joined the NIH's Child Health Institute as medical officer. In 2013, he was promoted as chief of pregnancy and perinatology branch, the first Indian-born American to become the chief within the Child Health Institute. At NICHD, he and his team managed more than 350 grants and contracts with an annual budget of over $500 million. In 2018, Dr. Raju received the NICHD Lifetime Achievement Award, adding to his 15 other NIH awards since his inception there. He is currently adjunct professor of pediatrics at the Walter Reed Hospital in Bethesda and the deputy editor for Journal of Perinatology, the official journal of the section on neonatal and perinatal medicine, American Academy of Pediatrics. Dr. Raju has published more than 350 publications, of which there are 36 chapters, 204 peer-reviewed articles, and 8 books. His book, The Importance of Having a Brain, tales from the history of medicine and a translation of Indian proverbs, don't stand in front of a palace or behind a horse, have received critical acclaim. So, Api is pleased to have him today. Welcome, Dr. Tonsei Raju. And please make sure to have your questions and answers routed through the Zoom, and we'll be moderating. Dr. Tonsei Raju, please.
Thank you. Let me see. I should get, can you see me? Oops. Okay. Share my screen. Yes. Can you see my slides at all?
Yes.
Okay. Okay, good. So let me start projecting that. Okay, there you go. Okay. Okay, first of all, I'm indebted to your, thank you very much, Dr. Janalgada and Dr. Murthy, especially, and Dr. Vasa. It's my honor and privilege to give this CME today to my API colleagues and other guests who have joined. As mentioned, mortality and health outcomes of preterm babies is a topic of my interest. Unfortunately, I don't have any conflicts to declare. I wish I had some, other than the fact that I work for the federal government. And as you know, no one in the federal government has any conflicts these days. All right. I have divided my talk in essentially 3 major components that I will present. One is, what is the status of premature baby outcomes today? And what are the outcomes as they become adults? And what are the implications for practice and research? So when we look at the trajectory of research in our country, over the past 50 to 60 years, a tragedy that occurred on August 9 in 1963 ended up galvanizing research into neonatal pulmonary problems. And many of you know this. President and Mrs. Jacqueline Kennedy's son, Patrick Boyer Kennedy, was born at 34 and a half weeks gestation, 21 10 grams, developed severe respiratory failure, and he died at 39 hours, despite having been transferred from an island off of Massachusetts coast to Boston Children's. And in spite of heroic measures, he did not survive. There was a national day of mourning. It was only superseded by another national day of mourning when Kennedy himself was assassinated 3 months later. But this tragedy stimulated lots of research. And my mentor, Dr. Vijayasagar, gave this talk and then has published this paper that gives you many more milestones that summarize the evolution of history of neonatology, which I don't have time to go over now. With the apologies to my neonatal and obstetric colleagues, just want a quick definition of what is preterm. So preterm gestation is anywhere from, we start from 20 weeks plus up to 36, completion of the 36 weeks is preterm. And within that, there are some subclassifications, and between 34 weeks through 36 weeks and 6 days. This period is called late preterm. This is very critical because this was defined at an NIH workshop, and that has really focused our attention on outcomes of late preterm also, not just very, very tiny babies. And then there has gone additional classification of term, and I'm not spending much time on that. So why is this topic so important? So let's look at the problem and what, how many premature babies are there in the country. 2018 data tells us that annually in our country, 3.8 million children are born per year. That's an approximate number. 10% of them are preterm. That's actually a huge number if you think of it, because it's any percentage of a large number, even as 10%, is a huge number. But within this premature group here, I think you can see my pointer, 70% are late preterm. So they are much more mature than very, very tiny ones. The really tiny babies, that is below 28 weeks and even below 31 weeks, form about 16%, below 28 weeks form 6%. So 6% of 10% is less than 1% of 3.8 million. I mean, it's essential to keep in mind, because people who are not in the neonatal field think that every baby we take care of in the neonatal nursery is an extremely small baby, 1 pound and 2 pounds. Yes, they are there, but they're also, we take care of much, quote unquote, larger premature babies. What is the survival rate for these babies? It's totally incredible if you come to think of it. During my own training days in early 80s, when a preterm baby below 1500 grams was being delivered, many obstetricians would not really bother to invite pediatricians to resuscitate that baby, because they would say, well, these babies are going to die anyway. Why want to bother the pediatrician to be here? But look what has happened. Probably, with the exception of pediatric oncology, no other field in medicine has seen such dramatic improvements in outcome. Here is a paper nicely summarized by my colleague and friend, Ravi Patel from Emory. In this paper, he summarizes the outcomes at every 5-year intervals, starting as early as 22 weeks of gestation and up to 25 weeks only. And look at the increase occurring from 23 weeks all the way up to 25 weeks. And in fact, if you look at the 50% of survival rate is seen already at 23 weeks. This is the data from 2013 to 2015. Now, even these numbers are even much, much better. Even this group, that is around 22 weeks, the numbers are improving. And so how can we summarize? And just for the sake of finishing this part of my talk, why do we need to worry about the adult outcomes? Well, one of this is, if you look at the babies born between 26 and 28 weeks, 80% survive. Below 32 weeks, 84%. Below 34 weeks, 90%. And in fact, more than 95% of all premature babies survive today. It's not at all a surprise that they are a very big number. Now, obviously, we all are worried about what happens to these babies. They are just surviving. Are they doing well? Once again, if you go back to the 70s and 80s, we were thinking that babies below 1,000 grams and 28 weeks, they had a very high, not only mortality, even survivors, nearly half of them would have significant brain injury. But things have changed. And as we see here, this is another study from Neonatal Research Network, also published by Ira Adams Chapman in pediatrics. And her paper shows that at 22 to 24 weeks and 25 to 26 weeks, this is a disability-free normal neurological outcome. I used her data from the table and converted into normal and any neurodevelopmental impairment. And that's what you will see here. So 72% for up to 24 weeks, babies are okay. And 86% of babies from 25 to 26 weeks are okay. And all of the babies, if you take all 22 to 26 weeks, then you will find nearly 81%. So I have summarized here, 80% of infants who are born between 22 to 26 weeks gestation have no neurological impairment. That said, they may very well have minor neurological problems as they go, keep moving on. There's one study that I can quote much more larger, population level research that was done in France. There are 9 regions of France. There's an incredibly interesting study. All children who were born in 1997, 1 year, every baby who was born in that region, 9 regions, in this gestation, 22 to 32 weeks, were followed up to 5 years. It's absolutely wonderful to see that. And then they had a appropriately matched control, 396 term-born babies, and they assessed the neurological outcome. What is the outcome in them? I have summarized the data on this table here. Cerebral palsy, visual deficiency, hearing, mental processing, gestational age below 32 weeks. Look at all the percentages here. So 8.8, 2.7. Mental processing composite score, it's a subtle issues. They are much higher problem with them. Bottom line here, 75% of them had no disability in premature babies of this gestation. And as compared to term was 88% had no disability. So even some of the term babies had problems too. So it's very interesting to see that. So in summary, in that study, 75% of very preterm had no disabilities. Disability rates increased with decreasing gestational age. Girl babies generally did better than boy babies. And a large fraction of infants had subtle disabilities that requiring special care. And also, this is the summary outlook for preterm infants today. This is only up to 5 years. What about all preterm babies? And what about when they go to school? There are many, many studies that I didn't have a chance to summarize that for this talk, but I'm simply going to say it's a very large proportion of preterm infants, especially those more than 28 weeks, remain disability-free if they do not suffer from severe neonatal complications such as ROP, retinopathy of prematurity, major intraventricular hemorrhage, or severe chronic lung disease. This is very good news. But then what about when they get to adults? That's what the question for the day here. So what is at any given time, how many people in this country, in our country, would have a history of preterm birth? Unfortunately, we don't have that number. No one has actually studied that. But I tried to compute it approximately. 2019 data, 328 million people were living in this country. And about 110 million of them were in this age range. So if you assume 10% of them were born as preterm, and about 80 to 95% of those preterm survived, one can imagine a huge percentage of adults living today would have a history of preterm birth. And given that, even a slight increase in the risk for adverse outcomes in such adults could have a major health impact. And therefore, that's why this topic is so critical here. And it is also very important to look at the life course perspective. It's not simply a baby is born preterm and then gets into trouble or does not get into trouble. The slides that the pictures I'm going to show now are done by my colleague and friend Satyan Lakshmi Simhan, who is professor at UC Davis. And these are beautiful pictures. So life course perspective. So there are husband and wife, there are pregnancy factors, fetal sex, multiple gestation, maternal illnesses, maternal and paternal factors, age, preconceptional factors, nutrition, environmental factors. And then what happens? All these, then the baby is born prematurely, let's assume. And then what are the consequences of premature birth? What is very essential for us to keep in mind is when a baby is born preterm, every organ stops growing intrauterine, in the intrauterine environment. And each organ has its own trajectory of maturation. They're not all similarly mature. Some of them are more mature, some of them are less mature, but they're all maturing. And suddenly they stop maturing and growing. And now everything has to take place postnatally. And then we do lots of things for them. We treat them and so on. Then there's maybe problems in nursery. We discharge them. Then the baby goes home. Then positive and negative factors are there. Breastfeeding, immunization. They go to school. And then there's a school environment. And then there comes the turbulent years of adolescent. Then there are positive and negative influences. Finally, there are adult outcomes. So whenever we are assessing adult outcomes, we need to keep in mind this life course perspective and then understand the context at which these are happening. So there is a life beyond the neonatal ICU, and some good nutrition, parenting, healthy postnatal course, regular checkups, good school and better job and more income, good classmates, better job should come further down, but good classmates, good peers, happy marriage and satisfied adult life. So a lot of things will happen, right? And the same way on the parallel side, things can go bad. There can be impaired nutrition, illnesses, poor medical care, poor immunization schedules, poor schooling, bullying by classmates, incomplete education, unemployment, spousal troubles, and dissatisfied adult life. So there is a life beyond NICU. So whenever we take a group of adults and try to see if they were born premature or not, we need to keep in mind there are other things that have gone in the life course of these people of the cohort we are studying. The folks from Scandinavian countries are very, very lucky. They have national cohorts. I mean, they can go back to 1940s and find out how many of those people who were born in 1940s ended up dying with a stroke when they turned into 70 years of age or plus, 80 years of age. They can get their all medication information of everyone in their country. I mean, unfortunately, in our country here in the United States, we cannot do that for premature babies. We do not have a national registry of premature baby outcome. That is one of the things I wanted to at least start at NIH when I was there. I did not succeed because I didn't think it was that important. There are other priorities. Anyway, here, after 2 years, we don't follow those babies. Unless you have a grant or a research project, after 2 or 3 at the most, babies are not followed up, even though the baby was extremely premature. Imagine if that was the case for oncology patients. If you say that, well, I treated your cancer, I know what happens after 2 years, but I don't know what happens after that. So that would be a tragedy. Anyway, that was my 2-cent argument why there should be a national registry. Now, in this study, my colleague Casey Crump, now he's in, when he was in Stanford, he did study. Now he's in New York. What he did was he took the Swedish national cohort, more than 6 million births, born in 73 to 79, who survived at least 1 year or longer. And then he stratified their mortality and computed adjusted hazards ratio. And this is the attained age on the x-axis, adjusted hazards ratio by gestational age at birth. And look at that U-shaped curve, 22, 27, 28, 33. This gestation, more of them would die early on. The risk for death will be high in early age groups. But when they turn around 20, there's not a whole lot of difference. But what is phenomenal is as the group ages, you see the steep rise, and it seems to be stacked up. This black line is those born term gestation. So compared to them, you will see the risk of death increases as age advances. And he also looked at what may be the causes. And I'm summarizing here. For each week of lower gestational age, hazards ratio for death from conditions noted below increased by an average value shown here, plus 95% confidence interval. Cardiovascular, 7%. Respiratory causes, 15% for every week lower gestation. So obviously, full gestation is very critical. Then, what about ischemic heart disease? Well, he recently published another set of data. And again, there was a relationship. These are all premature babies on these color bars, and horizontal is term born. And even babies who are born early preterm, there's a slight increase in their risk also. Adjusted hazards ratio was 1.53 for all preterm born adults at 30 to 43 years of age. So there is an increased risk for heart disease. And though that gets me to cardiovascular outcomes. It turns out that compared to full-term babies, the preterm baby's heart muscles are thicker and ventricular area is smaller. And as this is a very nice set of studies done by our friends from London, and they looked at preterm born young adults, different gestation, 28 weeks, 31, 28 to 31, and 32 to 36, and right ventricular mass per gram per meter square, or index. And you will see that right ventricular mass is much higher as gestational age goes down. Whereas when you compare the same to term-born adults, they are here, and term-born young adults, both young adults and a little older, below 20 years and more than 30 years. So these are, if you compare them, there's increased left ventricular mass. And similarly, they also have there's a difference in the gestational age. What is the effect of each gestational age? So here's a summary. I want to read it. Right ventricular mass increased by 2.5% for each week, gestational earlier week, and left ventricular mass by 1.8%. Similarly, ejection fraction also reduced by 2.3%, and ejection for also left ventricular ejection fraction by 0.4%. So there is even a functional element to this structural change. I'm not going to go into the details as to why the cardiac changes are there. We do not know all the answers, but typically from animal studies, it seems to show that there is ventricular hypertrophy, higher collagen deposition in the preterm models. And these probably are responsible for susceptibility. What about blood pressure? Well, this is a systematic review. I don't expect you to read those numbers, but the summary of the systematic review that was published last year, the mean difference in the blood pressure of more than 18,000 preterm born adults, whereas compared to 295 term born adults, systolic blood pressure was about 4.2 millimeters higher. Diastolic blood pressure was 2.2 millimeters higher in those who were born premature. Well, a few millimeters of mercury, does it make a difference? I know I'm talking to a lot of people in the audience here, maybe cardiologists. And compared to normal blood pressure, each 20 millimeter higher systolic and each 10 millimeter higher diastolic increases cardiovascular disease risk by twofold. So it's very important to keep this point in mind. Let's talk now about pulmonary outcomes. Now, it is once again, it emphasizes what I said earlier. Premature birth will stop the lungs at that stage when the baby comes out. And then rest of the maturation of the lung has to take place postnatally when we are doing all kinds of things to save them and put them on the ventilator, etc. And we know that in premature babies, airway patency is smaller, capillary density is thinner, and alveolar counts are lower. And it's much better shown in this slide. And this is on the x-axis, we have gestational fetal through birth and postnatal. And this is the lung structure. And now we have babies born at this stage, that is 24, 25 weeks. Look at, they're born at a saccular and canalicular stage of maturation. And all the maturation has to grow up, take place postnatally. So if there is a damage due to oxygen, ventilator, pressure, medications we give, etc., they can end up having less number of alveoli, and that can cause to chronic lung disease. So we can keep that in mind. That goes on to my next component within in the lung condition. Bronchopulmonary dysplasia, or a chronic lung disease, is one of the complications that we dread in the premature babies who have respiratory distress and who go on ventilatory care. In this study, they looked at 51 adolescents who had history of BPD. And I'm going to summarize simply what they did, a pulmonary function test. So FVV1 compared to those without BPD had much worse. And the BPD severity correlated with the severity of FEV1, that is forced expiratory volume in the first second. And here's another picture, another study from Dr. Lowering. He was in Oregon, and he actually has done many interesting research in this area. What they did was they really studied under exercise conditions. On the x-axis, we'll see increasing minute ventilation. On the y-axis, we see expiratory flow limitation. In the beginning, babies were born preterm who had BPD, no BPD, and term control. At the initiation of the exercise, not a whole lot of difference. But as the exercise increased, as they began to do more and more exercise, you will see in the preterm BPD and no BPD, you will see expiratory flow limitation got gradually worse. So across lifespan, what about the BPD outcome? That's a systematic review that once again confirms what I just heard before. There's evidence of higher frequency of airway obstruction. Airway obstruction correlates with clinical wheezing. Increased frequency of physician-diagnosed asthma. Again, once again, these data are coming from Scandinavia. There's a modest, inconsistent impairment in lung volumes and diffusion. So there is no restrictive problem, but there is some issue that we need to keep in mind. What is the reason why we should all know? So it is important for us to therefore elicit the history of preterm birth. I keep telling my students that premature birth or prematurity is a chronic disease. It is not just comes and goes and everything will be fine. It's not a chronic disease, but it is a chronic condition, probably. That may be a better term. Now, although I said there is a reduced exercise tolerance, we need to keep a perspective. Dr. Lowering told me that one of his patients, he was a former preterm. He was 28-weeker. He competed in the US Olympic trials, and he missed qualifying for the marathon race just by a hair. So he blamed, I was premature baby, therefore I cannot qualify into Olympics. So I would love to be able to run 1/10 of that marathon race without any problem. But so in some respects, one needs to keep a perspective on reduced exercise tolerance. What exactly does it mean? And I'm told by the adult pulmonologists that after 20 years of age, the lung function overall begins to deteriorate. So no more hope for many of us. The question is, individuals born prematurely, do they start going down earlier or more rapidly? That is still an unknown thing that needs to be studied more. Now I talk about kidney outcomes. Well, kidney is one of the organs which unfortunately neonatologists do not pay as much attention as we do for probably other organs. Maybe with apologies to my neonatal colleagues who are listening. Other than doing a kidney function test, which is a creatinine, which is really useless early on, the babies become hypernatremic, hyponatremic. We give fluids or we hold fluids, we give challenges. When everything messed up, we call pediatric nephrologists to help us. So unfortunately, that's the situation. But why kidney outcomes we need to worry about? Well, I'm told that adult nephron count is about 1 million. There's a wide range. Maternal smoking, vitamin deficiency, and many factors will affect that. But second and third trimester is the most important time period when almost 60% of human nephrons are formed. It may continue up to 40 days, and if the babies remain healthy, but many factors postnatally affect. After the baby goes home, in the neonatal period, many factors can negatively influence nephrogenesis. Hypoxia, ischemia, acute kidney necrosis, and damage due to various medications, including steroids and Lasix and other medications, antibiotics we use. So preterm infants are likely to end up with fewer nephrons. That is the bottom line. And early renal failure, therefore, in childhood, especially if a child becomes obese or has kidney infections, there's a higher risk of them developing renal failure early on. Here's a study that shows you the formation of the human nephrons. This is the 40 weeks term, 40 weeks here. And if the baby is born at 30, 34 weeks, and see how much fewer nephrons there are. So what is the relationship between kidney size, renal outcome, and age? There's one study that looked into that. There's a fair number of babies, 92 and 92 term controls. Young adults were born below 29 weeks. Keep in mind, these were all born in 1987. That is one of the problems when we do adults, I study adults, because you go back to 20, 30 years ago. We were not, hopefully we are taking care of the babies better these days than we did 30 years ago. Anyway, this study showed that kidneys, the premature babies had smaller kidneys and then higher urine albumin creatinine ratio and higher blood pressure. Just as I mentioned, it's like a few millimeters higher systolic and diastolic. And their blood pressure was inversely correlated with kidney size and being preterm. So then we'll go to the all-important brain outcomes. Well, most of us know that preterm infants are at risk for intraventricular hemorrhage, overt or covert periventricular leukomalacia, reduced white matter growth, and then they can have white matter injury due to hypoxia, inflammation, infection, and malnutrition. Once again, we need to look at the maturation of the brain, both in the fetal life and then after birth. It is beautifully shown in this picture. Early on, there's a lot of neurogenesis. Then the glia get formed, and we are talking about 24 weeks to 30. I'm not a neurobiologist, please. I'm just reading like most of you are. At 22 weeks, the brain is very smooth. Someone said it's like a mushroom. Even at 30, look at hardly any glial formation. By 34 weeks, when we think the baby is really nice and mature, compared to a 40-week baby, you will see still there is no general formation. And that continues beyond. Now, this is the term birth. And afterwards, this myelination continues. Synaptogenesis stops around here. But most importantly, there's synaptic pruning takes place. More and more, we are learning that much of this pruning is based on experience and repetitive, from learning and listening and family, talking, kids, engaging in conversation and so on. So this is very important to keep in mind. So assume the baby is born around here. And then there's a lot of trouble they undergo in the NICU, and you can imagine why there will be a problem. Okay, so all these are important: synaptogenesis and synaptic pruning. Here is a picture many years ago. Dr. Hannah Kinney from Harvard gave me this slide. Development of cerebral cortex, 20 weeks. 25 weeks is a neuronal arborization taking place. At 40 weeks, a rich forest-like phenomena here. And so when we look at the literature on brain outcome, there are some of the limitations we need to keep in mind. The various people who do various studies, the cohorts they select are heterogeneous in terms of gestational age and birth weight and so on. And they study at different age groups. And then imaging methods are different. And then very few functional correlate studies are there. So I have selected a few so that in the next few minutes we can talk about that. So let's look at white matter microstructure and executive function. This is a study that came in PLOS, a population-based study born in 1988 to 1993. It's a good size, 134 preterm, 94 term. They did the IQ and executive function measures. And then they did MRI studies in 71 preterm and 63 terms. And they also did 3D T1 weighted image, volumetric analysis, and diffusion tensor imaging to study the architecture of white matter microstructure. Once again, I'm no neuroscientist, so I didn't show this in this particular study. From this study, I didn't show the MRI pictures, but I have other ones coming down. But this group, preterm and term, there was a difference. Preterm babies did have lower IQ, 5 to 7 points for fewer IQ and subscores, that IQ subscore within that, and 1 to 3 point lower executive function measures. And there was no correlation between white matter microstructure and abnormalities of IQ scores. So we did a systematic review. I did a systematic review of this and published in 2017 in ACTA. And basically what we found, 28 cohort studies for their 4 systematic reviews. This is one of the conclusions. Disrupted brain development is a common feature. Smaller volumes of gray and white matter, globus pallidus, altered connectivity patterns, and so on. And also many compensatory new pathways. That's also fascinating. And there is higher cognitive dysfunction was correlated with disrupted connectivity patterns, less often with lower brain volumes. All right, so I think I have at least like in 10 minutes. And this study is interesting. Number recognition and math skills. The kids typically had difficulty in math. And they tried to look with the MRI, and I'm going to simply skip this. Healthy and high functioning young adults born preterm and full term completed a number of number symbols, and while they were doing the MRIs. And the conclusion was preterm babies used different parts of their brain when they were looking at those numbers compared to term babies. So the conclusion was healthy adults born preterm may recruit frontoparietal networks more extensively when processing non-symbolic magnitudes. These alternate pathways may be less robust, and they may be causing few milliseconds of delay in number recognition. Another study that was done, adults who were born preterm, looking at MRI, cingulum and fornix. Especially, it's easy to recognize them when they come with arrows and names, right? So this is the summated imagery from these British researchers. What they found was this is the control baby's volume of brain, of these tracts. And when it comes to very preterm normal, there was not a whole lot of difference. But those preterm babies who had perinatal brain injury had much smaller fornix, dorsal cingulum connecting medial frontal, and so on. So summary in terms of structure, what is the summary of the brain and cognitive outcomes? Well, Changes in key set of brain areas are seen, regions critical for behavioral and cognitive activities. Cortical striatal thalamocortical connections may be affected, leading to difficulty in integrating sensory information. Cognitive and emotional problems in high percentage of preterm adults could be explained by these brain areas having problems. And this is a fascinating work too from Bavaria. They tested a what neonatal factors can predict adult cognitive abilities. Then they took a very low birth weight infants born in 85 to 86 in the southern Bavaria and tested them when they reached 26 years of age. I'm summarizing the conclusion. The factors, the negative factors, we are not surprised when the babies had RDS, intraventricular hemorrhage, mobility problems known early in life, mechanical ventilation, and a low and middle socioeconomic strata in the family. The positive factors were all contrary. Good early parent relationship, parenteral feeding, high socioeconomic status, the oral feeding, that's very important, especially now breast milk. And then absence of negative factors. But what struck me, their conclusion is this line. Every day of mechanical ventilation dropped IQ by 0.43 points. How many times that I postpone extubating a baby from ventilation because I'm worried about what may happen over the weekend. So we need to keep double thinking about that, these numbers. But on the other hand, the good point is the good early parent-infant relationship increased the IQ by 5 points. So there are many other things, as I said, that happen after the baby is discharged. One quick summary about the mental health. There are 17 cohorts that have been studied in 2 systematic reviews. These babies had, the adults had higher, or adolescents especially, higher frequency of anxiety and depressive symptoms. They may be subjected to bullying, and their more traumatic transition between childhood and adolescence, and higher frequency of neuroticism and withdrawal. But thankfully, they also have less criminal and risk-taking behavior, less smoking, less drug and alcohol abuse. They are more dutiful, cautious, shy, reserved, and not aggressive. And fewer of them had romantic relationships, and fewer had teenage sex, which might make parents somewhat happy. In any case, so the final bit of information that I want to show you is aging. Do adults get aging faster? They age faster if they were born preterm. Here is a fascinating work done by the New Zealand group of researchers. They looked at the facial aging. So what they did was they took a cohort that was followed up to 38 years of age. Their high-risk perinatal factors were scored, and they brought the photographs of those patients to Duke. And undergraduate students at Duke were shown these pictures, in a very, very controlled manner, asking them, how old do you think this person is? The next question, is this person younger or older than 38 years of age? And then they also measured leukocyte telomere. And here, this half of the face you can see much more younger than this half. So what did the students think about? I mean, to me, this is fascinating, but the human eye can pick up things that probably no other machine can measure. And forget about that. That's, we don't have time to explain, but this is summary here. Adults with more perinatal adverse factors had earlier facial aging and more adult onset diseases. And they also had a shorter telomere length. And so there's a cellular aging along with facial aging. So something very interesting. And this paper was sent to Dr. Alan Guttmacher for review, and they also asked him to write an editorial, and he invited me to join him. And so this is the title we wrote with apologies to Wordsworth. The child is father of the man and mother of the woman. And so adults with more perinatal adverse factors have early aging, more adult onset disease, and so on, I just mentioned. Okay, so still we have a lot of major knowledge gaps. Sex and racial ethnic group difference we don't know, and we don't have a mechanistic understanding. And then what are the effects of lifestyle factors? Diet, exercise, smoking, family and school environment. International implications in India. More and more premature babies are surviving. What is the long-term adult outcomes? Effects of changes in neonatal care. Now there is more non-invasive ventilation we are doing. Newer medications we are using, or we are using older medications for newer indications. And what about the resiliency? Now, why not every premature baby who was born lower gestation get into huge trouble? What makes them get better? So these are things that we really need to study. So in summary then, overwhelming majority are healthy and well. A small but significant fraction are at slightly higher health risk. The effect size is probably small, but given the fact that it's a large percentage, we need to educate the teachers and parents to be aware of it, and healthcare providers to ask the history of preterm birth, even when they see adults in their care. This is the practical practice implication. Seek the history of preterm birth in clinical practice. Additional details of birth and perinatal health may be available these days. And since they have potentially earlier manifestations of metabolic syndrome, I didn't go into detail. You can implement earlier preventive measures. So I began with a tragedy, a story of a tragedy of President Kennedy's child. But this is the statement President Kennedy wrote while he was signing the NICH, creating NICHD. He said, adult behavior, intelligence, and motivation are established by the experience and patterns of response developed in the formative years of life. This he wrote as a footnote while he signed creating National Institute of Child Health. That was in 1962. What a prophetic statement. So with that, I had to end and tell you, in spite of all this, there are many people who have been born premature and they're very famous. So Isaac Newton, Voltaire, Sidney Poitier, Stevie Wonder. Unfortunately, he ended up getting oxygen, too much oxygen, and ended up getting ROP. But, you know, brilliant singer. So thank you very much.
Thank you, Dr. Raju. This is an enlightening, informative presentation. We are very thankful to you. Now, in light of the time constraints, we have about 12 minutes for the question and answer session. Dr. Rohit Wasa, please.
Thank you, Dr. Murthy and Dr. Raju. Phenomenal presentation. And, years ago, neonatologists were criticized for thinking about health of the preterm only when discharge occurs from the neonatal unit. And Dr. Raju has very eloquently mentioned that we are worried about the long-term outcome as much as adult outcomes. Hopefully, we would go outside of the research setting and use this for clinical. There are a number of questions. So I also want to thank Dr. Ramanathan for answering 2 or 3 questions that came in chat box. One of the questions that came in is the role of genetics and epigenetics. And Dr. Raju, do you have any thoughts on that?
Well, I have thoughts, but I'm no expert to even talk about it. I know as much of genetics and epigenetics as most of us just read from textbooks. But while we're reading this, there is not a whole lot that people have looked into in the adult cohorts. You know, they have not looked into the parents and what are the gene modifications that can take place. In terms of epigenetic, potentially what we do to these babies, cardiac hypertrophy may one of the epigenetic phenomena. We do not know that. I mean, I'm just guessing. So that is absolutely a very, very rich area for future studies.
Thank you. There was also a question on the outcome difference between babies who are born in a rich family versus poor family. And Dr. Ramanathan answered that question that there are socioeconomic factors that have an impact. Your thoughts?
Absolutely. What I still do not know is what are those factors in the rich family versus small family, not rich family, that makes the difference. We still do not know. What is it? What kind of It's the environment, it's the way the child is brought up. They're able to send these kids to a better school. There's one fascinating study I didn't have time to go into. There was a 1995 study about how often parents talk to their babies. And this study was done in Kansas. It's a very famous study. It turned out, I think they had 52 families only. Each family, every month, they went 1 hour each and recorded the conversation that took place. And they had 1,200 hours of conversation to compute. Finally, they came up with saying, poor families who are on welfare, those kids were exposed to 30 million words less compared to those who are professionals. And this became a huge news, 30 million word gap between rich and poor. That study has been criticized for a lot of methodological issues and so on, but there may very well be, whether the parents will talk with the child. I mean, we know that the first 2 years is extremely critical for language development and how well the babies are. So yes, that's very important question.
Taking the same concept further, the effect of race was also a question.
Right, very true. What happens is the Scandinavian countries, there's relatively a homogeneous population. That's where they have, data going back to the 1930s and 40s. And recently they have started looking into the immigrant population into their own countries. And unfortunately, there's a lot of people who move out and move in. And so we don't have a whole lot of, and they are also, the immigrant population tend to be in Scandinavia, a little poorer, relatively speaking. And so how much of that is an issue? And in our country here, we need to definitely see, we don't have any data on African-American, Asians in this country and Indian children who are growing up in this country, and Hispanics. We still need to study those things.
One more question. How does the upbringing by grandparents come into picture? Does it matter in terms of outcomes?
Fascinating thing. I mean, grandparents talk a lot, and we should use that that attribute more often, I think. Grandparents tell stories, and as you know, telling stories is an important method of learning. So that would no one has studied that effect of grandparents, but I can only see the positive effect of being a grandfather. You don't have any difficulty of raising the kids, but you can spoil them, as my children remind me when I look after our grandkids. But
spoil them and give them back.
That's right. That's an interesting thing too. Yes.
And another question on the chat box was, is there a relationship between preterm birth and spina bifida?
No, I have not studied. I mean, I have not come across that at all. I mean, that's not, obviously my talk for today. To the extent that folic acid deficiency was the main thing that was known. And since the supplementation became more common and regular now, we are seeing much less. In fact, there was a spina bifida study, intrauterine repair, the study from NICHD, and it went on and on because incidence of the condition became less. And I do think that spina bifida likely, if you do an intrauterine repair, they may end up becoming premature. Yeah.
Thanks. There is a question about the fertility rate, whether there is a difference between the fertility rate. Dr. Ramanathan answered saying that there is none.
There's one study that said there is no difference. I think Dr. Ramanathan is much ahead of me, so he knows.
No, I want to thank him for his jumping in the chat box. One other question, what do the effects in terms of level 4 treatment like ECMO and other level 4 treatment have on the outcome?
We know outcomes in terms of, there are two factors here. One is what led to the baby requiring those kinds of therapies and what were the potential negative effects of that on various organs. And then the effect of treatment itself. Unfortunately, we don't have huge numbers. Yes, No, Ram, you can keep talking. So we don't have a large number of cohorts to study that. And I do not recall anyone studying into adult age group, but there's a ECMO registry, and probably those people may be able to study ECMO outcomes, long-term ECMO outcomes.
And any interaction between prematurity and IUGR that affects the outcome?
Right. One of the biggest questions that we still, in these studies, all these studies that looked at preterm birth and adult outcome, they did not look at the reason why the baby became preterm. In other words, was it a maternal issue, an emergency cesarean because mother started bleeding? Or was it preeclampsia? She had very high blood pressure. Or was it SGA? The baby's growth was affected intrauterine. These are all very important. As we know, nearly half of preterm labor occurs spontaneously and without any maternal or known fetal issues. So there may very well be some effect of this, and this has not been studied in large databases. So maybe I can ask my friend Casey Crump in New York to do this. Yep.
Another question just came in. The physiology behind right ventricular mass being more prominent in preemies.
You know, the whole field of the musculature, both right and left ventricular mass being large, is still not very clear. I mean, there's one study that just got out in pediatric research about a year and a half ago. They looked at the autopsy studies of babies, fetal death, premature baby death, and babies who lived for a while and term, and concluded that they didn't find those issues of cardiac hypertrophy, whether it is a postnatal, whether oxygen-induced damage to this musculature happened, remodeling of the heart shape that should have taken place did not take place. So we don't have any clue about those. Some animal studies are there, but other than that, again, that's not my field of expertise, but I'm just reading some of those. It's a fascinating field for more people to do work on that.
Dr. Vasa, I think we got time for one more question, please.
Sure.
Thank you.
There's only one question left, otherwise I handled all of them. The last question is, cardiac septum defects and tetralogy have a higher incidence in preemies. Any reason for that?
I have no idea. You can, if you know the answer, please tell them. I'm the first one to say when I don't know something.
I didn't know that the incidence was higher in preemies.
No, I didn't know that either.
Well, that takes care of all the questions. Thank you very much. Very enlightening talks. Thank you very much.
Yeah, thank you, Dr. Vasa. Now, I think, at this point, I request Dr. Jonalagada to honor our distinguished speaker, Dr. Raju, for his outstanding contributions to pediatrics and neonatology. Dr. Jonalagada.
Thank you again. Thank you, Dr. Vasa, for outstanding moderator today. And very, very enlightening talk, Dr. Raju. And as a gastroenterologist, I learned a lot today about the babies. Okay. And indeed, thank you again. And Dr. Vijay. Vijay, can you put the slide on, please? The American Association of Physicians of Indian Origin recognized Dr. Tanse N.K. Raju, MD, DCH, for his outstanding contribution to pediatrics and welcome him as a member of API Distinguished Speaker Club. Sudhakar Jonalagada, MD, President, and Dr. Vemuri Murthy, Chairman, API Webinar CME Committee, December 20, 2020. Thank you very much, sir. Thank you very much for your presentation today.
It's my honor, and thank you, and all happy holiday and happy Christmas and happy New Year.
Yeah, thank you.
Thank you.
Good night. Good night. Stay safe.
Thank you. This concludes our CME program. Stay safe. Happy holidays and happy New Year.
Thank you.
Good night.
Good night.